What does it mean to be a true innovator? Well, today I've got Dr. J.H. Sanders joining the Hart Hustle podcast, and we're talking about how in 1969, he knew that telemedicine was going to be the future of patient engagement. We're going to talk about how his story of being a resident in a major metropolitan hospital and a conversation that he had with a doctor changed the future of healthcare. But one thing we should also recognize, sometimes when you're an innovator, you are also early. Now, in this conversation, you're going to hear Dr. Sanders talk about how he was challenged to be able to have technology be the bridge to engage with people from across the country, some of the challenges that he saw, what the future of artificial intelligence looks like in healthcare, and how we can continue to innovate to make massive changes. Let's get into the episode.
One of the things we both knew was that because of the lack of specialty care, specialty expertise in these rural hospitals, when a patient came in and required specialty expertise, they were immediately transferred out of the hospital to a secondary or tertiary care center. The problem was that reduced the bed census of the hospital, and eventually the bed census went to a point where the hospital had to close. It didn't have the revenue stream. Economics 101. In rural America, the major employer in town is usually the hospital. So when the hospital goes under, the entire socioeconomic fabric of that community goes under within a 3 to 5 year period of time. So he was not only looking for telemedicine to support the healthcare, he was looking at it to support jobs and support the underlying fabric of the community. That became the model, for good or for bad, became the model for the rest of the country.
So when we first hopped on with our call together, you had mentioned that there was a day back in 1969 when you had professors who introduced you to telemedicine and artificial intelligence. Let's tell that story.
Oh, sure. Well, I actually need to go back 2 years before that, 1967. I was a third-year resident at the Massachusetts General Hospital. In those days, they didn't have an emergency medical specialty. So the medical resident, the surgical resident, each took 12-hour shifts running the emergency department. And I was there that particular shift, and all of a sudden the doors of the ER swung open, and I, of course, expected EMS to be there, bringing in another classic Boston traffic accident victim. When no, standing in the middle of the door was my professor of medicine, Dr. Kenneth Bird, who was sweating and red-faced. And he looked at me and he started walking rapidly towards me. And of course, I knew exactly what he was going to tell me, that he got caught in the Boston traffic again. And now, why was that important? Well, Ken had an office. He was medical director at Logan Airport Medical Station. Now, anybody who's been to Boston knows that Logan Airport and the Mass General are only about 3 miles apart. What in the world could be taking him so long? The traffic. And the Sumner Tunnel, which was in those days the major tunnel. There was no Ted Williams Tunnel in Boston at that time. So the traffic was lined up on both sides of the tunnel, and he was once again caught, and took him an hour to go approximately 3 miles. And he said to me, he started walking rapidly toward me, grabbed my arm, and I said, "I know, Dr. Bird, I know you got caught in the traffic again." He said, "Yes, but I had an idea. What do you think of it?" He said, "What if I buy 2 TV cameras?" Now, remember, in those days, it was only black and white TV cameras. What if I buy 2 TV cameras and I set one up at Logan Airport Medical Station and one here at the MGHER, and Instead of having to travel over there, I could examine them from here. What do you think? Now, remember, I was a resident. He was my professor. I thought it was the stupidest idea I'd ever heard of in my life. But I had enough common sense to say, gee, Dr. Berg, that's a very interesting idea. He then went from talking to me to the general director of the Mass General, Dr. John Knowles, who was an equal maverick to Dr. Berg and used to have crazy ideas, brilliant ideas. And John gave him the money to buy 2 black and white TV cameras. And by 1969, we had everything set up, and Dr. Berg started to examine patients over TV. Now, he also came to me and said, Jay, you know, I don't want to call this television medicine. He said, let's just call it telemedicine. I said, that sounds good. Well, that's how we started. I also need to tell you that something very dramatic. All the clinical chiefs of service loved being on TV. So they were examining patients using the black and white TV, except for one. And he was Dr. Tom Dwyer, who was the chair of the Department of Psychiatry. Think about that. The chair of psychiatry said, this will never, ever work in my field. And what is ironic is today, mental health care is one of the biggest uses of telemedicine. However, Ken Berg, being the maverick that he was, got some grant money and gave it to Tom Dwyer. And 3 years later, the entire Department of Psychiatry wrote a series of articles on the incredible effectiveness of telepsychiatry. What they found was something that if they had asked a movie director ahead of time, the movie director would have said, well, of course, we create the emotions of a scene, not simply by the dialogue and not simply by the way the facial expressions of the actors, but also how we shoot the scene. And what Tom Dwyer found out was that when he got to a point with his patient that he wanted to really drive the thing that he was saying home to the patient, to think about, he used to move into the camera and make his head the only thing the patient saw. So this came like a message from above. And when he felt the patient wasn't ready to deal with the situation, he miniaturized himself by moving back from the camera. And it wasn't as critical for the patient in the patient's eyes. So that's how I got started in telemedicine. Now, the flip side was how I got started in AI. One of the things, now this was 1969 now, and I was now chief resident in medicine at the MGH. And traditionally, every week, the third-year residents would go and find a difficult case in the hospital and present it to me as an unknown and listen to my explanation, good or bad. And this particular day, they presented me this complex patient. And at the end of the session, I was thinking to myself, you know, I think I did a pretty good job with that one. And just as I was thinking that, I got a tap on the back. And I turned around, and it's another one of my professors, Dr. Octo Barnett, who if you Google him, you will see that he's identified by most people as the father of bioinformatics. Octo, by then, while he was a cardiologist by training, he had gotten into computers, and he had computerized 1969. It computerized the MGH laboratory and pharmacy. I mean, that was unheard of. So he taps me on the back and he said, Jay, and he has this, I won't say it, he had this grin on his face. And he said, Jay, you can be replaced by a computer. 1969. I said, excuse me, Dr. Burnett? He said, yeah, you could be replaced by a computer. And he started talking to me about AI. And I got interested in it with him and started to do some work with him. But both of us quickly found out we didn't have the computer power, 1969. And some people will remember, those who are at least as old as I am, had MIT tried to be the AI center in the mid-'80s. They also found out they didn't have enough computer power. Today, we have all the computer power we need, and with quantum computing coming in, we're there. So very early on, I got started in telemedicine, which I could do because the telecommunication industry was exploding with new technology and capabilities. So we could do it. There was only one problem. I forgot about our federal government. I forgot about people. Silly me. And I couldn't get anything started in telemedicine. Well, I did after in 1973, when I was chief of medicine at the University of Miami, Jackson Memorial Hospital. I got a grant from the National Science Foundation to apply telemedicine into correctional healthcare. And we demonstrated after a 3-year period of time, and I started the first nurse practitioner program in the state of Florida, that nurse practitioners using telemedicine, connecting to the academic medical center, were as good as board-certified physicians physically on site in the correctional facility. So from 1973 to 1976, I did that, and then I could not get anybody interested in telemedicine until, believe it or not, 1991, when I received a call from the governor of the state of Georgia, Governor Zell Miller. And he invited me up to meet with him, and he said, I would like to develop a statewide telemedicine system. I was blown away. I think I ran up there rather than taking a plane. And when I met with him, he put his hand out to shake my hand, and he introduced himself as the governor of 2 states. And I looked at him somewhat quizzically, and I said, excuse me, Governor Miller? And he said, yes. He said, Jay, I'm the governor of Atlanta, and I'm the governor of the rest of Georgia. He said, the rest of Georgia is a rural state. We have everything we need here in Atlanta, but we don't have enough health care in the rest of the state. To make a long story short, I developed a 59-site hospital-to-hospital telemedicine system connecting 3 academic medical centers with 9 comprehensive community hospitals, each of those in turn connected to rural hospitals. And one of the other things that Zell Miller taught me, other than being the governor of 2 states, was Economics 101, which they had never taught me in medical school. And what he told me was that, he said, one of the things we both knew was that because of the lack of specialty care, specialty expertise in these rural hospitals, when a patient came in and required specialty expertise, they were immediately transferred out of the hospital to a secondary or tertiary care center. The problem was that reduced the bed census of the hospital, and eventually the bed census went to a point where the hospital had to close. It didn't have the revenue stream. Economics 101. In rural America, the major employer in town is usually the hospital. So when the hospital goes under, the entire socioeconomic fabric of that community goes under within a 3 to 5 year period of time. So he was not only looking for telemedicine to support the healthcare, he was looking at it to support jobs and support the underlying fabric of the community. That became the model, for good or for bad, became the model for the rest of the country. State of Arizona administrators and academicians came to see the system. They set up the system in Arizona. Then the state of California came. They did the same thing. And now if you look, it is the model for just about every state in the country.
I want to talk a little bit about those early days when you experienced the aha moment of technology being the bridge to increase access to medical access and healthcare services. Didn't it seem like the mass implementation of that was just around the corner?
It did in my mind, but yeah, it proved how incredibly naive I was then, and I remain today, about how long it takes to get people to change. It's really terrible, and it's quite candidly, it's cost thousands and thousands of lives. It really has, and incredibly disappointing. I wish I was not, here I'm going to make a confession, I wish I was not 87. I wish I was starting all over again. I remain as frustrated now as I was then about how long it takes for people to recognize the need for change. I mean, look what it took in this country. It took thousands of deaths. It took COVID to get people to change.
It's so interesting to me that we have had such a similar experience. I told you for everybody who's listening and watching today, that the first company I started was a telehealth, telemedicine company in 2014. And I had the same eureka moment that you did when a bill was passed here in the state of Nevada, Assembly Bill 292, that said you could have a virtual interaction with your doctor and it could be reimbursed as if they were in the office. The first thing I did was, this is going to change the world. I ran out to healthcare systems and as many people as I could possibly talk to and said, there's going to be a future for this virtual interaction. Nobody believed me. So what did I have to do, Dr. Sanders? I went to the jails in rural counties of Nevada and said, we can use this virtual connectivity for psychiatry services and mental health assessments. Those were the first people who bought into the idea because they had challenges because of the financial elements of transferring inmates from the actual jail to the hospital, about $1,500. So I had to pull on the element of the cost savings in order for them to believe in this idea. It's amazing to hear you went through the same experience.
Yeah, same experience. And that is why the correctional healthcare system in Florida in the 70s wanted this, because in the state healthcare system, they usually have to send 2 guards with an inmate into the facility for those costs. In the federal system, they sometimes require 5 guards to go with an inmate. Huge costs to them and huge liability for them. So that you and I had the same experience. I wish I was as young as you.
It's interesting how our stories weave together, because in 2014, I also met the CEO of Zoom, the connectivity platform that we first met on. And the reason why I was so attracted to their technology is they were architecting a video communication platform that was supposed to run on mobile devices. The infrastructure of connectivity was so much lower, needed to have a good asynchronous video and audio connection. And so I said, this is my telecommunications boom that I can take advantage of, and we can go directly to the patient. And that is how we continue to leverage telemedicine from a direct to consumer model instead of a hospital system with the other educational institutions as well.
We connect again because I know Eric Wan very well. And Eric was initially with Cisco and had developed WebEx for Cisco. And then he went off on his own to develop Zoom. And I met him after he was playing. I met him in his living room with a cast on his ankle because he had been playing soccer and hurt his ankle. Very interesting.
So let's talk about kind of, I want to talk about the innovator's mindset. So in 1998, you were the founder of the American Telemedicine Association. 1993, excuse me. So what were you thinking about in forming the association at that point in time? Did you feel like momentum was behind you and you needed to start indoctrinating different institutions and leaders across the country to be behind this vision?
I wish I could say that. No, it was literally just about a half a dozen of us who were enthusiastic about it and said, you know what, let's start an association. And we started in 1993. We didn't have our first national meeting until 1995. And there were 400 people in the room. I thought the entire world was in the room. Okay? I could not believe there were 400 people who were interested in this. And then it just started to take off. But once again, the difficulty we had related to interstate licensure issues, and which still bugs me as to why we haven't solved that, because it's a very exceedingly simple way to solve it. And number two, no one would pay for a telemedicine consultation, so you couldn't get physicians interested in doing it, except the rural-based physicians who were getting continuing medical education. That's the other thing we didn't mention about telemedicine into rural communities. Yes, it helped the economic base. Yes, it helped the patient. But also what everybody forgets is it helps the primary care physician, and it helps the retention of those physicians, because there's a huge exodus of physicians out of rural communities. But what this did was to bring the specialist to the primary care doc. The primary care doc started to learn how to do these things and therefore felt more confident in dealing with these patients and said, gee, you know, I can stay in this community. I will admit, I probably shouldn't say this, but I will. One of the biggest supporters today of telemedicine is the American Telemedicine Association. You know who used to be one of the biggest obstacles to telemedicine? The American Telemedicine Association.
Wow.
It wasn't until, pardon the expression, money. When the government started to reimburse for it, the American Telemedicine Association, the American Medical Association was totally in favor of it. But prior to that, we couldn't get them involved. As a matter of fact, a lot of people don't know this, and I will probably be finger pointed at after saying this, but around 1998, we tried to break the logjam related to interstate licensure. You know why there is a legal problem with interstate licensure? Because of the definition of where medical care occurs. For some strange reason, The definition of where medical care occurs is at the location of the patient, not the location of the physician. Well, if we just change the definition to the location of the physician, telemedicine is totally legal, and my license in my state of Virginia can take care of you in Nevada. I don't have to get a Nevada license.
There was an interesting caveat that we tried to leverage when we started our company called the originating site fee. So there was a reimbursable code. I want to say it was like code 3016 or 1065 or something like that, that said that you can bill as an originating site fee for hosting the telemedicine interaction. And we thought that that money lever that we would pull on would get people to adopt this technology. But something that's really interesting is we're talking about this problem from two different perspectives, which I think is really unique. I was coming from the perspective of the patient experience in using telemedicine to create efficiencies. I used an example in our previous conversation. In 2015, one of the first large government institutions that I went to say, we can do telemedicine on these little devices or iPads with digital cellular connectivity was the VA. Now, when we went to the VA, they said, this is great, but this doesn't fit our model. Let me tell you why. We just invested $1.6 billion into telemedicine equipment in the form of a 65-inch television with a tilt, pan, and zoom camera. And the expectation for them, the VA, was to use their global or their national network of healthcare providers to come into the VA, but they expected the patient to travel 2.5 hours or 3 hours from the middle of the desert to come to the originating site and sit in front of a television screen. A huge disconnect in consumer behavior.
Totally disconnect. And by the way, just one, subscript to that. If you look at the makeup of the veteran population, 2/3 of the veterans come from rural areas.
So why are we not thinking about the consumer experience in healthcare today more often? It took a global pandemic for us to switch our view. But one of the things that I talk about, Dr. Sanders, is the world that we live in today, whether you like it or not, is based on the idea of convenience. We have people who will come to your door and drop off food. They will take you to the airport. They will deliver things directly to you. You never have to leave your home. But the way in which we approach medicine has been completely different. We still expect for the consumer to come to the location, if you will, of course, when appropriate, to the doctor, cancel all their daily appointments, sit in a waiting room, and then have to see their doctor on average for 5 minutes when they have to do 15 minutes of documentation. It seems like we have to change some things up.
Oh, you're 100% correct. But let me expand that, magnify it a bit. Give me a little preface time. We're talking about telemedicine. To me, telemedicine provides access to care. One thing it doesn't provide is accuracy to care. Okay? I can give you multiple examples in which this has been studied, and I hope nobody in the audience is actually listening to what I'm about to say. But the fundamental reality is that we wonderful physicians kill thousands of patients a year from inadvertent medical errors. It's not, we don't do it purposely. We do it because we think we're dealing with this disease when in fact we're dealing with a totally different disease. Or we think the best medication for this disease is X, when in fact it's really Y. And why is that? Because we haven't kept up with the literature. And I can give you references for the studies that have actually been done to demonstrate this fact, one of which was the Institute of Medicine, now the National Academy of Medicine, 1999 study called To Err is Human, and a Johns Hopkins study in 2015 in the British Medical Journal saying, no, the Institute of Medicine study was wrong where it said we killed 98,000 people a year. The British Medical Journal article said, no, it's closer to 215,000 people a year. Now, I think most of the people who might be listening to this are never going to go to their doctor again. I don't necessarily blame them. But with that said, it's great if you have telemedicine, but if your doctor is out of date, it's not so great. AI is going to bring accuracy to that conversation. It's going to bring collective expertise to the bedside, not just a single physician, but multiple specialists to the bedside. Okay. Medical sensors, which we haven't talked about, most people wear today with their Apple Watch, okay? And they'll be wearing them in their tattoos, okay? They'll be wearing in their belts. Under Armour puts them in the shirts for the National Football Combine so the coaches can watch the performance, the physiological performance of the athletes as they're going through, say, the 100-yard dash. These already exist. Now, if we now integrate yours, not mine, your genetic makeup into those sensors with AI, we're going to go from statistical healthcare, which is what healthcare is today, based on statistics. We're going to go to precision healthcare. What your medicine needs to be for your condition versus I might have the same condition that you have, but I have totally different genetics. And my sensors with my AI are telling me exactly that. And I need to be on a different medication. That's what access, accuracy, accountability will cause the most important change in healthcare. And that's going to be accountability. Right now, we go to the doctor when we're sick. The doctor is reacting to your illness. We need to prevent the illness with the sensors that are telling us, look, your heart rate is up, you're overweight, you shouldn't be doing X, Y, and Z until you lose weight, and this is what you should do to lose weight. Our system today is reactionary instead of accountable. And that's what the new technologies are going to do for us. But don't ever ask me how long that's going to take, because look how wrong I was.
We are at an interesting intersection in time where since November of 2022, OpenAI, one of the largest AI conglomerate companies, has released technology that the American people are getting used to interacting with. I hear a lot of statistics where over the last generations, on the internet at least, people have become very used to communicating and searching ideas on things like Google, which opens up the idea for a lot of, I would say, subjective, diagnosis of information, right? Very dangerous. People always talk about the WebMD. Don't search what you are feeling from a symptoms perspective on WebMD, because you're going to think that you have brain cancer, even if you just have a runny nose. What people are starting to do now, Dr. Sanders, is they're going to things like ChatGPT and they're asking questions. They're putting in information about their life, their lifestyle, and they're getting more accurate diagnosis from a system because it has more data to make decisions and discernment about. The thing that I think is going to be very interesting is a project that we've been working on, once again, coming from the consumer perspective of healthcare. I used an example in our last conversation. Exactly. This is in our previous conversation. I mentioned in 2019, I ruptured my patellar tendon, right? Went in for surgery, was discharged from the hospital with the classic packet of information. If you have a question, go refer back to this. I never referred back to the packet. I think I lost it as soon as I got out of the surgery center. What we are doing now is we are using conversational AI with simple text messages AI that is trained on all of that discharge paperwork, best practices, education, and allowing for the patient to then text a conversational expert who can guide them through best practices, guidance, point them towards additional resources. This, from my perspective of the consumer, is more proactive in allowing for them to go to a trusted resource to be able to obtain information about their condition rather than being reactionary and saying, I have no idea what's going on. I'm going to go back into the hospital, AKA a readmission that dings the hospital system on surgery and education and everything else like that. What do you think about that paradigm shift we're in?
First of all, I think you're 1,000% correct. But if you want to be 10,000% correct, you need to integrate your genetic profile into that. Now, people may be thinking, whoa, genetic profile, so forth, and so that's very expensive. That how do you do that, and so forth and so on. First of all, the very simple, easy way to do that. When you and I were born, well, when you were born, not when I was born, they stuck your heel to take some blood to look for what's called inborn errors of metabolism. Okay? Today, the cost of a genetic analysis is way down, so that now that same drop of blood could be used for your specific genetic analysis. Okay? Now you integrate that genetic analysis into the sensors and into the AI. And now you go from you're looking at what you need to do or using your phone to look up what you need to do. Because the answer you're going to get still today with AI is statistical. It's not going to be specific. With the genetic analysis programming your AI and your sensors, it's specificity. And you and I are different. And we're going to respond differently to that aspirin that we both take at the same time. That's precision healthcare. And now we need to get the federal government and the insurance companies to switch the payment mechanism to, for instance, what you do when you get life insurance. When you get life insurance, they do a physical exam. If you smoke, if you're overweight, what happens? For the same amount of life insurance that I may want, say $100,000 worth of life insurance, and you want $100,000 worth of life insurance, if you do all the things I just said, they're going to charge you more than they're going to charge me. Because you're overweight and you smoke, and the likelihood of your dying sooner is greater. Okay? I want that same thing for any medication I might prescribe for someone. I want to look at what their genetic profile is and have AI say, okay, for this genetic profile, don't use this weight reduction medication, use that one. That's when we have a responsible healthcare delivery system. And I wish I would be alive to see that, but unfortunately I won't.
I'm hoping for something different. I want to look at this as an opportunity, Dr. Sanders, instead of a challenge. Now, one of the opportunities that we have in front of us is we could also encourage the large EHR gorillas like Cerner and Epic to be able to allow people to get fluid access to all of their healthcare records so that AI could also be smarter. In our previous conversation, we talked about the compartmentalization of healthcare data. I want you to kind of tackle that for the audience.
Yeah, absolutely. I mean, the biggest problem we have is compartmentalization of health data. The Office of the National Coordinator, the ones who certify medical records to be EHRs, are the ones who are at fault. Because they said, I think back in almost 2014, 2015, in order to be certified, you have to be interoperable. yet they have never, ever enforced that. So if I have a chronic illness and I've been seen by a primary care doc who uses Cerner record and been hospitalized in one hospital that uses an Epic record and another hospital that uses eClinical work, those three don't talk to each other. There is a system out there, but I don't, since this company is a consulting client, I'm not going to mention it, but there is a system out there that polls every 30 days, legally and agnostically, from every single electronic medical record you've ever been exposed to, normalizes the data, synthesizes the data, and time sequences the data so that when you're looking at their record, it's your complete record. Now, why is that important? AI has to interpret all the data. To me, this client's capability is the linchpin that does it. Why ONC doesn't require it is amazing to me. It's almost as if ONC is being driven by the private companies. I probably should have zippered my mouth before saying all of that.
Well, I think that your perspective is a healthy one because this is how informed people in this space also feel. We see the writing on the wall where there's simple solutions to these macro problems, but it seems like we continue to go down the same path time and time again. And unless we are hitting people where it hurts, aka in the pocket, we're not actually going to see the changes that the American people or the global society of healthcare really deserves. So let's cast a vision, Dr. Sanders, for the future innovators, the future entrepreneurs who are seeing these problems very much like you did in 1969, actually in 1967, like I came across in 2014, where it seemed like the writing was on the wall, but it seems like we're fighting against macro problems and gatekeepers who are stopping us from innovating in this space. What would be your advice for these people?
You need to run for president. I don't know what it's going to take. I thought just simple logic would solve the problem. It doesn't. Look what we're going through politically here in this country. I better not say anything else about that. I've spent a lot of my life being incredibly naive about the reality of this country. I hate to end on that sort of down note, but that's real problem we have. It's not just medical care. I mean, everybody forgets one very, very simple medical fact. Except for a few unfortunate examples, when we are born, we're all born with 46 chromosomes. None of us had a choice as to who we were born to, what their religion was, what their economic status was, what the color of their skin was. Total chance. Every single one of us. Why don't people look in the mirror and realize that? I mean, the prejudice that exists, the religious animosity that exists, the economic differences that exist. Just amazing to me. I just can't wait until the next intelligent species takes over this planet. I apologize for being a bit depressive, but I'm talking reality.
And Dr. Sanders, maybe we're already seeing that with the invention and the mass adoption of artificial intelligence. Maybe the logic is going to now be grounded in data and macro perspectives of our collective genius that is hopefully someday going to help us make the changes that we all deserve.
That's the other reason I'm going to vote for you for president.
Yes. In 2042, everybody, you know where to look for. Mr. Hart is going to try and reunite the heart of this nation. Well, Dr. Sanders, I just want to say, man, thank you so much for joining this conversation with me. It's been an absolute pleasure. And it's, been so cool to be able to sit around somebody who came, in all due respect, lifetimes ahead of me, but we have been on the same path. And I think that's what the beauty of this conversation has been about as well. I appreciate your time, man.
Well, only appreciation is for me to thank you.